Hi, good morning, everyone. I want to preface this with two apologies to start. The first is if I grimace or wince, it's because I was stupid and fell on the ice this weekend and have a significant amount of lower back pain, so I apologize for that. The other is I had two really exceptional clinicians that were supposed to be here today and do this presentation. One of them ended up having to schedule an outpatient procedure for today, and the other one had childcare issues. So unfortunately, you're stuck with me, who may not be the expert on this, but I was willing to be here and happy to be here with the invitation. Prairie St. John's, for those of you who don't know, it's a 110-bed psychiatric hospital in Fargo. And all we do is psychiatric and addiction issues. It's really what we specialize in. The foundational belief for the Zero Suicide Project is that we don't want a reduction of suicides. If I asked you what reduction would you accept, would it be 10%, would it be 20%? Well, of course, we want 100% reduction. Any suicide, a singular suicide is too many. So the primary goals are to reduce, certainly a reduction in suicide, improve cares for actually those people getting help. And the toolkit for the Zero Suicide Project comes with 7 sections. It's to lead a system-wide culture change committed to reducing suicide, training to have competent and confident and caring workforce, up to date in suicide care, identify patients with suicidal risk via comprehensive screenings, to engage all individuals at risk of suicide in a suicide care management plan, treat suicidal thoughts and behaviors using evidence-based treatments, transition individuals through care with warm handoffs and support contacts, and to improve policies and procedures through a continuous quality improvement process. The Zero Suicide implementation for us, Universal Health Services, which is our parent company, is a corporate sponsor for the Action Alliance Network. And this is a summary of actually what we did at Prairie St. John's in moving towards a zero suicide philosophy. And I'll go through each of these in separate slides. So, the OHS Work Plan, again, is creating a leadership-driven, safety-oriented culture committed to dramatically reducing suicide among people under care. It's really intended to assess the strengths and weaknesses of our organization and what's currently in place, and develop a work plan that actually improves the process and systems. And it's a guided change to ensure suicidal individuals don't fall through cracks. And it's really these steps through the cultural change, screenings, assessments, access to care, and again, development of our workforce. A lot of what we did was around staff development and training. We've spent countless hours training our staff to look at patients and work with patients differently. Safety planning, and again, restricting the access to lethal means, effective treatment, and using as a quality QI process. So what we did, we sent a survey out to all of our staff. We have around 400 staff, so we felt that 240 participants was a really good response rate for our staff, over half. And they really identified 3 areas that they felt they needed extra training on. So the workforce tool really did assesses our knowledge, our practices, and then the confidence in which they are practicing, and then help determine the needs. And the needs really came out as communicating with patients. How do we communicate with patients about suicide? What family and caregiver and community supports are there? And certainly the prevention and awareness piece. What we did then is implemented 3 trainings for our staff based on that feedback. And those were more skills on motivational interviewing, a crisis response plan and reasons for living, and the ASIP, which is the Attempted Suicide Short Intervention Program. So we had all of our clinical staff go through these trainings. And we also had CALM, which is the Counseling on Access to Lethal Means. It's an online resource through the Suicide Prevention Resource Center. And then we also made it available through all of what we call health streams, which is our internal intranet for education and training. The therapists and discharge planners found this to be very, very helpful with safety planning, because it provided a tool and questions to gather better information about access to lethal means. And it was really done in a non-threatening way. So you weren't getting in a power struggle about gun rights and gun control and who had what, and it really minimized that conflict. And the safety planning for access to lethal means was really very temporary and focused on a reduction rather than an elimination, because the more we tried to move to elimination, the harder pushback we had from patients. So we helped them understand that this is a temporary change through this critical time and access. The safety planning, also through our resources, was another training resource made available through the Zero Suicide website. It considers potential triggers and available resources to develop a collaborative plan of what a patient will do versus what they won't do. We don't contract for safety anymore. I think as clinicians, that used to be something we always would fall back on and go, well, we have a document that says they're not going to hurt themselves. We contracted for safety, but the studies have shown that they're really very ineffective documents. They really don't carry much weight with the patients. So a good safety plan really provides a range of options of things that I can do by myself and that don't require somebody else, but it's also to a more therapeutic social situation with AA meetings, places of worship, where they can get support at higher levels than 24/7 access for crisis services, and then certainly emergency services. We also require all of our employees to go through AMSR, and that's the Assessing and Managing Suicide Risk. It's a 6.5-hour full-day training session, and we do it for all of our employees, and all of our new employees also have it. And it goes beyond just with the normal risk factors. We look at managing our own attitudes and our own approach to how we work with suicidal patients. It's getting the right information to appropriately formulate a better risk plan. And the risk formulation itself compares someone at their own functioning level. Some of our patients we see multiple times, so it's not, here's Joe again, he's always suicidal, but okay, here's Joe, and is he more suicidal than he normally is? Versus trying to say someone, here's acute, here's someone medium, here's someone with low risk. How do we really anchor that assessment, where we try to put it in better perspective and take a lot more collaborative information to it. And it's also helpful in identifying both resources and potential triggers that develop a safety plan of a patient's understanding of what they will actually do. And the big piece, what we also use, is working with First Link. First Link fills a gap that we just couldn't fill. Part of our organizational study found that post-discharge wellness calls were a real area of concern that we just couldn't meet. So we partnered with First Link to ensure they're getting done, and the partnership has been very, very successful. The call reminds patients of their discharge plan and their follow-up appointments to make sure that they understand their plan. It also has a safety check on it and redirects the patients back into crisis services and emergency treatment if that patient's still struggling. And research shows that quick check really makes a huge difference in those patients' lives. The two numbers I didn't put here, First Link did make over 8,200 phone calls last week. And it's not just for Prairie St. John's, they do it for a variety of organizations. But through their 211 hotline call, I got a note from Cindy yesterday that let me know that they had over 10,000 calls this year. It was 10,161 calls to the 211 hotline, and that's incoming calls where they made 8,200 calls outgoing for providers. So obviously a huge presence, and since you're all in Bismarck today, I would encourage you to talk to your legislators, because there's a very important House Bill 1329, and I don't want to be political because it's not my thing, but that is a main funding piece for First Link. So if you do happen to run into your legislators while you're in town, please ask them for their support for House Bill 1329 that goes to First Link. That's something that we all need to do as advocates for our services and care. So, and that is my presentation. Do you have any questions on what we're doing at Prairie St. John's? Yes.
You mentioned a couple of trainings, ANSR and ASSIP. Are those done by your staff or do you bring someone outside?
The question was, is the AMSR training and the ASIP training done in-house or not? The ASIP training is an online through the suicide prevention link website. The AMSR training, we sent our staff out to a corporate training, and they came back as train the trainers, and they do our training internally.
In your facility, when you have a person who has been suicidal, before discharge, what kind of education does the family get before their discharge?
The question was, what kind of education do we do with families around discharge? We have an expectation that if the patient allows us through releases of information to include the family as much as we can. One of the problems we have is that we are a regional treatment center, so we serve patients from all over North Dakota, South Dakota, and Minnesota. So that's one of the struggles we have in discharge, including families who may be coming from Duluth or Minneapolis or Sioux Falls, or even out in Williston, those areas. The communication is not as good as it needs to be. So we do have an expectation as part of our discharge plan to include the family as much as we can. And that's something that we honestly, we do struggle to do because of the geography of where our patients are coming from and how many bridges they have sometimes burned over their lifetime. So it's something that we struggle with. I'm honest about that, but we do try very, very hard to include the families because they're a big piece of the support system. That's actually why we're trying to look at extending our services out to the western side of the state and possibly opening a program out there. We have to work with the state on some funding issues around that that are bigger issues, but it's a goal of ours to look at opening a new program out in the Dickinson area and creating a unit out there because it's such an underserved part of the state. And we know that because they're coming here, hundreds of thousands of dollars are being spent a year moving people back and forth in ambulances that could be better put into treatment, not transportation. If you have any questions, I'll be here for a little bit before I go back and lay down. So please stop and ask. Thank you.